like to thank the organizers for inviting me to present our abstract entitled PrEP Uptake Amongst MSM, Accessing Sexual Health Services in Ontario and British Columbia, the preliminary results of our PrEP community survey. I'm presenting on behalf of my co-investigators and on behalf of our senior investigator, Dr. Daryl Tan. Here are my disclosures for this presentation and the disclosures of Dr. Tan. As you all know, gay, bisexual, and other men who have sex with men, hereby abbreviated GB-MSM, constitute the majority of new HIV diagnoses in British Columbia and Ontario, making up over 50% of all new diagnoses in each province. HIV pre-exposure prophylaxis, or PrEP, using standard tenofovir and emtricitabine, is standard of care for HIV prevention amongst GB-MSM and other populations at risk. And we've published national guidelines to aid clinicians beginning in 2017. Provinces in Canada have adopted different strategies for PrEP provision. Here, if we compare PrEP programs between British Columbia and Ontario, we can see in British Columbia, clinical guidelines were first made available in 2014. A provincial program supported through the BC Centre for Excellence in HIV/AIDS was made available beginning in January 2018 with publicly funded PrEP for individuals meeting guideline criteria. And for MSM, these would include having a HIRI risk index over 10, prior rectal STI or syphilis diagnosis, having an HIV positive partner with undetectable viral load, and almost 6,000 individuals at this point have now accessed PrEP. In Ontario, tenofovir emtricitabine was made available for PrEP use in September 2016, but coverage is either through private health benefits or some individuals will qualify for the provincial drug benefit program, and PrEP has been available in this manner since 2017. There are no specific or explicit criteria for starting people on PrEP. Data for PrEP in Ontario is lagging. An OHTN report published in 2019 suggested 3,600 individuals had accessed PrEP by June of 2018. Despite the availability of PrEP in both provinces for the last 18 months, other data has suggested that the uptake of PrEP amongst MSM has remained relatively low. And in the ENGAGE cohort presented at CAR last year, in looking at individuals enrolled in Montreal, Toronto, and Vancouver, between 14.5 and 21.8% of those surveyed across those three sites had actually used PrEP by 2019. And the low uptake of PrEP may be derived from low levels of self-perceived risk where individuals don't identify as needing PrEP, potential systemic barriers, including lack of provider awareness or provider comfort in offering PrEP, and potentially financial concerns if individuals are responsible for paying for this medication themselves. We undertook to evaluate PrEP knowledge and PrEP uptake amongst GB-MSM accessing sexual health services in British Columbia and Ontario. Here we present the first results of the PrEP implementation study. This is a CIHR-funded implementation research project evaluating PrEP implementation in both British Columbia and Ontario. Its main goals are to evaluate the PrEP cascade of care for eligible GB-MSM seeking sexual health services in these provinces, and specifically focusing on higher risk individuals who would benefit from PrEP, defined on the basis of a HIRI-MSM risk index over 25, having a prior rectal STI or a syphilis diagnosis. The participating sites in British Columbia include Vancouver and Victoria, and in Ontario, sites are enrolling from Toronto, Hamilton, and Ottawa. In addition to the system-level cascade of care, we've undertaken a quantitative survey evaluating PrEP awareness and use amongst individuals seeking sexual health care in these cities, and are complementing this with a qualitative longitudinal interview series to evaluate lived experiences and perceived barriers to PrEP use. I present now the preliminary results of our quantitative survey. Here, GB MSM accessing sexual health services in these participating cities from July 2019 to February 2020 were included. And I will point out that enrollment for the study continues. Individuals could participate either through direct enrollment and participation in the survey while attending a clinic visit, or may have been given a link to the online survey if they had accessed any of the sexual health services. To participate in the survey, individuals had to be over 19 years of age, have reported sex with a male partner in the last 6 months, and have accessed either HIV testing or other STI services or counseling in a particular participating city. The survey assesses obviously baseline demographics, has a number of domains assessing sexual health and HIV risk assessment, looking at the HERE risk index or self-perceived risk for HIV and STI indicators, and obviously looked at PrEP use, grouping individuals to those who had reported never using PrEP at all, individuals who were on PrEP at the time of the survey, and individuals who had stopped PrEP, having previously been using it. We present some very basic summary statistics and bivariate comparisons of proportions in this presentation. Here are the results of selected demographic criteria. The mean age is very similar between the two provinces at 33 and 34 years respectively. We have quite a diverse group of individuals taking part in this survey, with less than 50% of individuals identifying as white. For individuals who may be interested in the other ethnicity breakdown, one of the other groups would have been Black individuals at approximately 9% so far among survey participants. Indigenous individuals were self-identified as only 2 to 3% of the total population. The majority of individuals in the survey did identify as gay. And there were some differences between Ontario and British Columbia with reporting of individuals identifying as either bisexual or other identity, which could include queer or two-spirited. Here I present the results of our data looking at how often people are testing for HIV. We can see there's a significant difference between individuals in British Columbia and Ontario who report frequent testing at between 1 to 6 months in nature, with a significantly higher proportion of people reporting use of PrEP. This data goes only up to the end of 2019, so the overall denominator is slightly smaller than the denominator reported for the demographic data. We also looked at HIV risk indicator. Here we can see a majority of individuals in the study have had a prior STI. These are overall rates for gonorrhea and proportions for gonorrhea and chlamydia. I have not yet broken them down to site. In addition, the proportion of people presenting with a HERE risk indicator over 25 is about 10.8%, very similar to other data seen in momentum studies presented previously by Dr. Lachowski. And a very small proportion of people in the survey self-identified as potentially being at high risk for HIV. If we look now at PrEP uptake, we can see that there was a significant difference between British Columbia and Ontario, with over 40% of individuals in BC reporting current PrEP use compared to 18% of individuals in Ontario. And conversely, Ontario had a much higher proportion of people who had never used PrEP in the past. If we look at some of the reasons reported for not using PrEP, the most common reason was a low self-perceived risk for HIV. Concerns about side effects was a reason for 32% of individuals. 19% of individuals reported concerns regarding cost, and other concerns included needing to use a regular medication. In direct comparison between provinces, the only significant difference were the proportion of people reporting concerns for cost. As might be expected, as BC does not have significant cost barriers. We can see in these preliminary results from our PRIMS quantitative survey that PrEP use remains modest amongst GB MSM accessing sexual health services, with only 28.5% of individuals as of February 2020 reporting PrEP use. There were high rates of self-reported STIs, and these may indicate HIV risk, but lower rates of self-identification of HIV risk amongst participants. PrEP use was seen to be higher in British Columbia, and cost may have played a role in access. There are some strengths to the survey. This is a large sample across 2 different provinces. We have significant ethnic diversity amongst our participants. But there are some limitations that could explain some of the differences. Firstly, individuals in BC were recruited from sexual health clinics, which also are directly offering PrEP, and we may have surveyed a population that was more likely to be on PrEP for this reason. This could also explain why we're seeing higher testing frequencies in BC, as individuals may be testing on a quarterly basis as per PrEP guidelines. Our data is ongoing with further data collection, and this will allow us to evaluate PrEP uptake, potentially amongst higher risk individuals targeted for PrEP. I'd like to acknowledge the CIHR for research support and our CAB members and all participating sites and staff. Thank you very much.